This program is brought to you by Emory University.
Good morning, everyone. Welcome to Heart and Vascular Grand Rounds, Monday, February 24th. We have a special guest joining us today, Dr. Gregg Stone. I'm going to turn it over to Bill to introduce Dr. Stone for the Grand Rounds this morning.
Yeah, thanks, Praddock, and thanks, Greg, for being here. So Dr. Stone is pretty much as prolific as you can be in our field. So anybody that doesn't know who he is either actively avoided reading the literature or lived under a stone, but he's basically pretty much legendary in the field right now. But he did his medical school at Hopkins in Baltimore, and then did his residency at Cornell. Did general cardiology out at Cedars-Sinai in LA under Dr. Swan from the Swan-Ganz catheter, and then did his fellowship in advanced coronary angioplasty with another legend, Jeffrey Hartzler, out at Kansas City. Greg was a director of TCT for 24 years, largest symposium for interventional cardiology and vascular medicine. He's the one who founded the National Interventional Cardiology Fellows course, which I think we've all gone to through the years in interventional cardiology. He founded TVT for valves, founded Chronic CTO Summit, and co-director of multiple other meetings around the world. He joined Mount Sinai back in 2019 as professor of medicine and director of cardiovascular research and education for the Center of Interventional Vascular Therapy. I met him back when he was at Columbia. Prior to that, he's held similar positions previously at Lenox and Washington Hospital Center. He served as a national PI or international PI for over 150 trials. He's got over 3,000 manuscripts authored. For people who know what an H index is, his is 206, which puts him in the top 0.01% of all clinical researchers. Really recognized throughout the field. He's been very diverse. I mean, not really just been into ACS or MIs, but he's been very involved with resorbable scaffolds, left main, complex PCI, but also extends into valvular interventions. IVIS, OCT really has been spanned the spectrum of our field and has been probably one of the most impactful people in the profession. So it's a real privilege to have Greg here. He's been a big supporter of Emory through the years and has really led the charge. And so he's going to talk today about who are appropriate candidates for revascularization in the post-ischemia era. So thanks again, Greg. It's a privilege to have you.
Well, thanks, Bill. It's great. It's great to be here. I wish we were in person. As we were talking, we've gone to a virtual world, but I know you guys still do the Emory course, which has always been amazing and one of the highlights of the year. And so what I'm going to try to do is we're going to go over some bread and butter stuff. It's kind of the beginning of the academic year, and we're going to talk about a big topic, but a topic that we've had, increasing clarity in many patients, and that's who's appropriate patients for revascularization in the post-ischemia era. Ischemia, of course, referring to the ischemia trial, of which I was one of the principal investigators. So we thought we're going to start with chronic coronary syndromes, and we thought we knew a lot about chronic coronary syndromes and why we do PCI until a real seminal time came out, and that was the Courage era. And that was 20 years ago, in 2007. This trial hit us all in interventional cardiology like a ton of bricks. And this was a trial of PCI with mostly bare metal stents at the time versus optimal medical therapy versus medical therapy alone, the first big randomized trial of its sort. And there was absolutely no difference in death or myocardial infarction or either component at follow-up to about 4.6 years. And we were really grousing about this trial. There were a lot of reasons that we were coming up with that it may have been negative, but basically while patients felt marginally better, they had somewhat less angina, at least in this study, there was no reduction at all, not even a hint for an improvement in prognosis. And then later, this was replicated with in Berry 2D with first-generation drug-eluting stents. This was a trial, of course, in patients with diabetes and multivessel disease without left main disease. That were randomized to either medical therapy or revascularization. Revascularization could be either here PCI or bypass surgery. And once again, there was absolutely no difference in death, myocardial infarction, stroke, or the primary MACE endpoint. When you looked at the PCI and CABG stratum, there actually was a reduction in myocardial infarction in CABG and nothing with PCI. No difference in death with either strata. And the CABG strata, it might be because of CABG compared to PCI, but this wasn't randomized CABG versus PCI. And the CABG stratum was a lot more complex with a lot higher incidence of prior MI, triple vessel disease, proximal LAD involvement, CTOs, et cetera. Perhaps explaining why the MI rate was reduced. But still, this was a positive endpoint from a subgroup of a negative trial. So right now, after Berry 2D, it looked like not much difference in death and MI for revascularization and stable coronary disease. So then we were thinking, well, maybe neither of these trials enrolled sick enough patients, at least patients not with enough ischemia. And there have been, I could show you 100 slides relating the extent of ischemia as quantitatively measured with a poor prognosis in terms of increased cardiac death and increased myocardial infarction, and a relative better outcome in a non-randomized fashion in patients who happen to get revascularized. So this is a study from Cedars-Sinai Medical Center that's been quoted probably 10,000 times. They do a great job quantifying ischemia on SPECT. And they looked at over 3,000 patients who had 2-year follow-up. And as you can see in the red line, looking at the rate of cardiac death, this is the log of cardiac death. So these lines are actually exponential, not straight. That the greater the amount of ischemic myocardium, the greater the cardiac mortality in the red line in patients treated medically. Now, in patients who happen to be treated with revascularization, it seemed like once you got to about 10% ischemic myocardium, that then, those were high-risk patients, and it did seem like over that point, there was a benefit in terms of revascularization. But again, this is just associations. It's a non-randomized trial, but maybe ischemia predicts the difference in revascularization benefit. And a lot of the patients in both Courage and Berry 2D did not have a lot of ischemia. Probably 2/3 to 3/4 of all the patients had less than 10% ischemia or even no ischemia, despite having coronary artery disease. So this was our hypothesis going into the ischemia trial. And in ischemia, as you know, we took a total of 8,518 patients, and we did a blinded CT in the majority of the patients that didn't have severe renal insufficiency to make sure that they actually did have coronary disease and that they didn't have left main disease. And then we randomized a total of 5,179 patients to either an invasive strategy, which meant go to the cath lab, define the coronary anatomy. No, and I'm sorry, all these patients had 10% or greater ischemia according to one or more functional tests. Could be a cardiac SPECT, dobutamine echocardiography, MRI, PET, et cetera. And then, so 10% or greater ischemia, stable coronary artery disease, and then we randomize them to either an invasive strategy of going to the cath lab, defining the anatomy, and then choosing the best revascularization modality in a non-randomized fashion, either PCI or CABG, or a conservative strategy of not even going to the cath lab, knowing that these patients have coronary disease in most cases, because that's what the CT showed, and they've got 10% or greater ischemia, but just treating them with medical therapy and reserving cath for medical therapy failure. And you can see that in the invasive therapy arm, about 60% of the patients had PCI, about 20% had CABG, and about 20% had medical therapy, because either the CAD wasn't severe enough for revascularization, or in some cases it was too severe. It was just too much diffuse disease, multiple chronic totals, dead myocardium, patients that couldn't be benefited by revascularization by either PCI or CABG. And importantly, this trial enrolled only patients with very mild symptoms. In fact, about 1/3 of the patients had no angina at all, and about 2/3 of the patients had class 1 or 2 angina. So the idea was we didn't want people who are going to have a high rate of crossover from the conservative arm to the invasive arm because they were having a lot of symptoms. We wanted to see if we could improve prognosis in patients who mainly would stick to their as treated regimens. We also excluded patients with LVEFs less than 35%, with severe heart failure, and again, acute coronary syndromes. And we also excluded patients with an eGFR of less than 30 mLs per minute, Those patients went into a parallel trial called Ischemia CKD. So by, again, not knowing the anatomy, we included incredibly complex patients in this trial because the medical therapy arm never had their anatomy defined. So we avoided the oculostenotic reflex that was present in Courage, wherein not many patients with 90% proximal LADs were enrolled, and same with Berry 2D. With this trial, you didn't know the anatomy. And I can tell you, these are a lot of the worst patients we've ever seen in a core angiographic laboratory. Nonetheless, there was no difference between an invasive approach and a conservative approach in these patients. The primary endpoint was the composite of cardiovascular death, MI, or hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. And here you can see the 4 and 5 year data. The median was 3.2-year follow-up, and there was no difference between the two groups. Now you can see here, though, that the curves are overlapping, okay? So this is, I'm sorry, not overlapping, but they crisscross. So this is a classic case of non-proportional hazards. You could see early on, for example, in the first 6 months, there's about a 2% difference in harm in the invasive group. And that's because mostly of periprocedural myocardial infarctions of all patients who undergo revascularization procedures, even using a pretty strict definition of large periprocedural MI, still about 2% worse in this arm. But then there's actually a catch-up when you get to about 2 years. And at 2 years and beyond, there's actually slightly fewer events in the invasive arm compared to the conservative arm. So at the end of 4 years, there actually was a marginal reduction of 2.2% with a confidence interval that's barely touching 0%. So how do you deal with this when you've got non-proportional hazards? In fact, the hazard ratio, which is 0.93, is kind of irrelevant. So you can look at something called the restrictive mean event-free survival time, and that actually is basically the area between the curves. Here you've got an early hazard to invasive approach, which of course impacts patients for a longer time than here, the later benefit to the invasive approach. And overall, the invasive approach benefited patients by about 9.5 days on average, not having an event relative to a conservative approach. But you can see this has a very wide confidence interval, and so this was a negative trial. Now, could we find any patients who benefited? Well, these were all the key pre-specified subgroups we had, and there was really no difference according to diabetes, the degree of angina, the severity of coronary disease, whether proximal LAD was involved, triple vessel disease was involved, and even the degree of baseline ischemia. In fact, 12% of the patients, even though the sites said they had at least 10% ischemia, the core labs said they didn't. They had no or mild ischemia. But there's absolutely no difference with any of these groups. You can see the interaction values are all negative. Now, we did a few post hoc analyses, and we did find that the patients who had the most severe coronary artery disease, by looking at the Duke Jeopardy score, the patients who had a Duke Jeopardy score of 6, it appeared had a benefit with an invasive approach compared to a conservative approach. So these are patients with triple vessel disease with 70% or greater stenoses in all 3 vessels, or double vessel disease, including a 70% proximal LAD. And so the interaction effect here, though, was negative. So this was not a big enough group. Of the 5,700 patients, this was only about 600 patients. So about 10% of all the patients. Not a big enough group to make this a positive interaction effect, but it suggested that there might be a benefit among patients with very complex coronary disease. We also excluded patients with an LVEF of less than 35% or NYHA class 3 or 4 heart failure. But we did have patients with an LVEF of 35 to 40 or a history of prior heart failure or mild heart failure. And we'll talk about why we excluded those patients later. That was because of the SIDGE trial. And this was, again, a relatively small group of patients, only about 400 patients, but it did seem like this group of patients did benefit from revascularization. And here the interaction p-value is borderline, but you can see the curves look like the whole 2 sets of curves with these crossing curves at 2 years. If you don't have a reduced LVEF or prior heart failure, and if you did, then it seemed like there was really a greater benefit to vascularization. Now let's look a little bit into the components of the primary endpoint. And as you can imagine, about 80 to 85% of all the events were myocardial infarctions. And the myocardial infarction curve looks exactly like the overall curve, okay, because that's most of the events. So an early harm, and then a catch up, and then perhaps a little bit of a late benefit. So if you break this down into the procedural MIs and the non-procedural MIs, the procedural MIs, here's your increase, about a 2 to 2.5% increase, clearly higher with the invasive approach, all in this early period. If you look at non-procedural myocardial infarctions, though, you can see that there clearly is a benefit over time of an invasive approach. And this really cemented the fact that, yes, we do decrease non-procedural myocardial infarction with revascularizing patients with a large amount of ischemia and stable coronary artery disease. It's not a big reduction, it's about a 3% reduction, but it's very real. And if you look, at least in this non-randomized fashion, looking at type 1 MIs from the UDMI, Universal Definition criteria, these are the most prognostically important ones. We see about a 50% reduction in type 1 MIs with PCI, with CABG, and even with medical therapy in the appropriate patients that were triaged to medical therapy, a lot of whom had milder coronary disease. But when we look at death, and in particular all-cause death, absolutely no difference in all-cause death. And despite the fact that these patients had so much coronary disease, and they, 90% of them had 10% or greater ischemia, with a lot of them having 20% or greater ischemia, you can see the death rates are very low. It's about 1.5% per year, okay? And it's not at all impacted by an invasive versus a conservative approach. And most of these were cardiovascular deaths, but it's just a very low death rate. So first of all, you could see that the curves, there's almost no deaths in the first year. So first of all, in these patients, there's no rush. There's no fire sale here. Even if you feel, gosh, I'm not going to leave patients with 80% or 90% proximal LADs and triple vessel disease, you can, give the patients time to make a decision about what to do. And they're unlikely to die, and they're even unlikely in the short term to have a myocardial infarction. Now, when we looked at cardiovascular death and broke it down into cardiovascular, non-cardiovascular, no difference again. But interestingly here, the curves are spreading a little bit over time, okay? But the p-value is 0.33. If we look at now cardiovascular death to a longer-term follow-up, we've gotten an extension grant to extend ischemia out to 10-year follow-up. And this is principally going to be for mortality. If you look here at cardiovascular death, now with a 5.7-year median follow-up, so it's increased from 3.2 to 5.7, we're still in the process of this. Now you can see the curves are spreading. And now you can see that there is a statistically significant 2.2% reduction in cardiovascular death in the ischemia extended trial out to 8-year follow-up. Now, counterbalancing that is the difference in non-cardiovascular death. And this is a little harder to understand or explain, but those curves also spread as well. And there's a reduction in non-cardiovascular death in those patients treated conservatively. So we don't exactly know how to explain this. This was not enough radiation to make, and this is not a long enough follow-up period for cancers to explain a difference in non-cardiovascular death. Most of these deaths were due to late infections, and not another cause we could find. So maybe this is a false positive, or maybe it's hard to adjudicate the differences between cardiovascular and non-cardiovascular death. Nonetheless, when you looked at all-cause death to 5.7 years, the lines are superimposable. So this depends on how positive you want to be. You can interpret this by saying there's absolutely no difference in death by revascularization in these stable patients, even though they have a lot of ischemia. Or you could say there's a reduction in cardiovascular death. And of course, that's all we could reduce. There's no reason we would reduce non-cardiovascular death. And by the way, I think that change in non-cardiovascular death is just play of chance and is not real. So we'll see when we get patients all out to 10 years, we'll see what happens to these curves. Now, if we put ischemia into perspective of all the other trials, and there have been a lot of trials of revascularization versus no revascularization in stable coronary artery disease, This is the latest, quote, mega meta-analysis of 25 trials, 19,806 patients randomized to PCI or CABG versus medical therapy with a mean 5.7-year follow-up. And this includes the ischemia earlier data, but not the later data. And you can see over here in this big meta-analysis, cardiac death is reduced by about 21%. So it seems like this is real, okay? But it's not very much. It's 0.3% per year. It's a very small difference in cardiac death. And we need to treat about 300 plus patients to reduce one cardiac death every year. Interestingly, when you look at and you do what's called a meta-regression, you can find that the longer you follow up patients in these different trials, the greater the reduction in cardiac death. So similar to what we saw in ischemia. We also see a significant reduction in spontaneous myocardial infarction. Here, this is non-procedural MIs, reduced by 26%, about 0.5% per year. So we are seeing some cardiac benefits by revascularizing stable ischemic heart disease. And these are not all patients with ischemia. This is a whole variety of different patients. But it's a very small difference, about 0.5% per year. And interestingly, if you can also, by meta-regression, relate the reduction in spontaneous MI with the reduction in cardiac death. The greater the reduction in spontaneous MI, the greater the reduction in cardiac death. And when you look at this reduction here, looking at both cardiac death and spontaneous MI, it doesn't matter whether it was PCI or CABG. It doesn't matter whether these were patients who were truly all stable coronary disease or were stabilized after an acute coronary syndrome. It doesn't matter whether the patients had a CTO or not. Okay, all the patients had this reduction, about 20% reduction in cardiac death and about a 25% reduction in spontaneous MI. What about all death, which we see on the left, and all myocardial infarction, which we see on the right? No differences. But there is a tiny trend towards a 6% reduction in all-cause death and a 13% reduction in all myocardial infarction. Okay? So there is no difference in death or MI, but the point of me pointing out these trends is that there also does not appear to be any harm. Okay? And there's been no trials, no large trials that have actually shown harm of these procedures. And if you look at these confidence intervals, again, you got the overall point estimate, 0.94, going from 0.87 to 1.01. So it could be as much as a 13% reduction in all-cause death and as much as a 1% increase. So there's really no chance that there's any significant increase in death, and similar for myocardial infarction. All right, so now let's leave the ischemia trial. And let's talk about the patients that were not enrolled. So let's start with left main disease. So most people, with a few notable exceptions, would not disagree with the fact that if you find significant left main disease, that patient needs to be revascularized. And they were excluded from ischemia. And the reason was because we have two randomized trials of bypass surgery versus medical therapy performed 40 years ago. Okay, the VA cooperative study and the European study that showed in 150 randomized patients, there was a marked reduction with bypass surgery compared to medical therapy in terms of 5-year mortality. And you can see it was reduced from 36% with medical therapy to 16% with bypass surgery. Now, this really wasn't even medical therapy. I mean, this is 40 years ago. There was no statins back then. There was no clopidogrel. Most of these patients were lucky to even be on aspirin, okay? But even though that is true, there was such a massive difference, and this is only 150 randomized patients. We hardly consider this a pilot trial now, okay? But nonetheless, this was such a massive reduction, and you can see within this 5-year period, you saved about 20 years of life. I mean, so you give people about 2 years out of 5 years back on an average. So nobody has really had the appetite to enroll patients with left main disease into a trial of contemporary revascularization versus contemporary medical therapy. So the bigger issue is PCI versus CABG. Okay, and as you know, we have 4 randomized trials of drug-eluting stents versus bypass surgery in 4,394 patients. And in this individual patient data, pooled analysis that was reported from Eugene Brunwald and Mark Sabatine and his colleagues, there was absolutely no difference in mortality between PCI and CABG for the left main disease patients that were randomized in these studies out to 5-year follow-up. In fact, 2 of the trials followed patients out to 10 years, and you could see the concern was that after 5 years, that's where the curves would start spreading. But here you can see that same minor little difference at 5 years, not statistically significant. And then by 10 years, the curves are actually converging. Okay, so we don't have any evidence of overall benefit of CABG over PCI for left main disease. However, we wanted to look carefully at the impact of other factors. Most other factors, male, female, younger, older age, diabetes, no diabetes, did not at all impact the analysis. But the one thing that did was the syntax score. And this is a continuous or spline relationship looking at the hazard ratio on the y-axis for PCI versus CABG according to the syntax score on the x-axis as determined by a core laboratory. And you can see up to a syntax score of about 33. Okay, there's absolutely no difference in mortality. In fact, if anything, the point estimate favors PCI. But you can see the red is the confidence interval, no difference in mortality here. But after a syntax score of 33, it starts to favor surgery. And when you actually get to a syntax score of around 45, now the 95% confidence interval doesn't cross 0 anymore, or 1. So now there was a statistically significant benefit of CABG. But you can see how wide the 95% confidence interval, there weren't that many patients in these trials with a syntax score of greater than 45. Nonetheless, though, I think this pattern is clear. And when you got high syntax score patients with left main disease, they probably will have some mortality benefit with bypass surgery, especially as you get to the very high numbers. Now, you've got to counteract this or counterbalance that with the risk of stroke. And there is about a 1% incremental risk of stroke in most series in the peri-procedural period of patients with any kind of coronary disease undergoing CABG compared to PCI. So there's about a 1% difference of stroke, which is pretty much maintained throughout 1 year. And then over the years, when stroke occurs for other causes, the curves somewhat converge and they're no longer significant. But there clearly is about a 1-year difference in stroke. So you've got to weigh, again, even in patients, there might be a mortality benefit in CABG with a little bit higher risk of stroke. Although these are pretty small numbers. You're talking about in the peri-procedural period about a 1.2% stroke risk versus a 0.2% stroke risk. So not very much. Now, what about multivessel disease? And what about the impact of diabetes? Well, in the left main patients, diabetes, at least from the data sets we have, really was not a determinant. And that's because the left main is a big vessel. It turns out it's easy for interventionalists to revascularize the left main. It's not hard at all. It's a big vessel with a short lesion. And even when there's the distal bifurcation involved, it's easy for us to treat the distal bifurcation because both the ostial circ and the ostial LAD are large vessels. Where we get into more difficulty with PCI is when we have diffuse complex multivessel disease. And this is where diabetes probably plays a factor. So here is a study that we did, again, and this is an individual patient data pooled analysis of all 8 randomized trials on 7,040 patients of PCI with drug-eluting stents versus CABG in multivessel disease. And here you can see that there was a clear advantage of CABG in reducing mortality in multivessel disease. The overall difference is about 2.6% at 5 years. So not very much. Again, it's about 0.5% per year. And you can see there's a little bit of harm, and then there's the benefit that crosses over about 1 year with CABG. But this is clearly, even though, again, this is technically non-proportional hazards, I think this here is pretty much a valid finding. And about a 2.6% difference in the long term. Now, when we looked at subgroups in the multivessel disease patients, here we found, again, not a big impact from age, sex, and not even as much of an impact from syntax score. But here, where we found the biggest impact to be was in diabetes. And if you looked here for mortality at 5 years in diabetics, in the diabetic group, there was a higher risk of mortality, both with PCI and CABG, but especially with PCI. So there was about a 5.5% difference in mortality. at the end of 5 years. And again, I'm a big believer in looking more at the absolute differences than at the relevant differences. If you tell a patient there's a 48% higher risk of dying, that might be meaningful, very, very meaningful. It sounds very terrifying. But if you tell the patient more accurately that there's a 5.5% chance of dying, 1 in 20 chance of dying over 5 years, that's easier for the patient to understand and then decide how important is that to the patient on what kind of risk they want to take. But this is about 1% per year. Okay, so that's an easy benchmark for people to understand. Now, in contrast, when you look at no diabetes, there was lower mortality and really no difference in mortality in either arm. So here there was a significant difference in the diabetic population. So diabetics with multivessel disease, they often have severe diffuse disease, and some of this is because of higher syntax score, but a lot of it is because of the targets. Okay, if you have a patient with multivessel disease and diabetes, and the multivessel disease is an 80% focal prox LED and a 70% focal circumflex lesion, that patient is going to do fine with PCI. Doesn't matter that it's a multivessel disease or not. It doesn't matter if the patient got diabetes. They got nice focal, easy to treat lesions. But when you've got patients with intermediate or high syntax scores with diffuse ratty disease, those patients are going to do better in general in terms of mortality with surgery. Now, once again, you have to offset this with the risk of stroke. And I bring up stroke because in many series, stroke is a bigger concern to patient than is survival. And you can see here, the 5-year difference in stroke is about 1%. So it's significant, and it's all within the first 30 days to 1 year. So again, there's a 1% difference in stroke, which you have to weigh against a 5% or 5.5% difference at 5 years in terms of mortality. To me, the mortality, I think 5.5% is probably more important than 1%. In non-diabetic patients, not so much. All right, now what about when you get to multivessel disease with LV dysfunction? Okay, now we're getting a little bit more controversial. So we've got only one really good trial, and that's the STITCH trial. And this was 1,212 patients with heart failure and ischemic cardiomyopathy with an LVEF of less than or equal to 35%. And they were randomized to CABG versus medical therapy if they had multivessel disease. It didn't matter whether they had ischemia, it didn't matter whether they were having symptoms. So you could see a third of them had no angina. Most of the remainder had minor symptoms. Okay, and most of the patients were NYHA class 1 or 2. But they were surgical candidates, so they're relatively young. The mean age is 59 years old, 88% were male, 40% had diabetes. And with follow-up through 10 years, there was a reduction in mortality with bypass surgery compared to best medical therapy at this time, which is about a decade, 10 to 15 years ago when this trial was performed. Now, this doesn't look like a very big difference in the curves, but again, this is on a 0 to 100% difference. So here you can see the number needed to treat to prevent 1 death was about 14. So this is about 7% overall difference. So about a 1% difference in mortality per year. And you'll note again that the curves cross, a little bit of an overall harm with surgery early on, but then the curves cross relatively soon. And when you follow these patients long-term, bypass surgery reduced mortality. At 5 years, which actually was the primary endpoint of the STITCH trial, this was a negative trial. But by 10 years, it became positive. So remember that when I show you the next slide. 1,200 patients took 10 years to become positive. We have one randomized trial in patients with ischemic cardiomyopathy and heart failure, and that's the revived BESIS-2 trial. So this was 700 patients with an LVEF less than or equal to 35%. Okay, and they also had myocardial viability, as they define as overall viability of more muscle rather than less. And they were randomized to PCI versus medical therapy alone. And here you can see these are older patients. They're 71. Again, male predominance, same 40% diabetics. And again, most of these patients, even more than in STITCH, had no angina. Okay, almost none of these patients were having class 3 or 4 angina. And again, the vast majority were relatively stable heart failure, NYHA class 1 or 2. And here in this trial, They followed the patients with a median 3.4-year follow-up, absolutely no difference in survival with PCI versus medical therapy alone. And if you look at all the other endpoints, there's no difference in any outcomes. Now, you could see here, there's a 1% difference in mortality of death from any cause. And maybe this is because we don't have 10-year follow-up. Again, the median is 3.4-year follow-up. The median follow-up was 10 years in the Stitch trial. It was 9.8 years in the Stitch trial. And this is only half of the patient size of the Stitch trial. So maybe it's not a big enough trial, and maybe we don't have long-term enough follow-up. But again, right now, I think the data is stronger for bypass surgery than it is for PCI for appropriate patients with ischemic cardiomyopathy. Now, I did mention the limitations of this trial, though, and if you do look at larger databases, for example, now we've got a propensity-matched non-randomized trial of 2,126 patients, 3 times larger than BSIS, from the New York State database with multi-vessel disease and LVEF less than or equal to 35%, at a median 2.9-year follow-up, so still pretty early. Now there's no overall difference in mortality. Hazard ratio between PCI and CABG of 1.01, 0.81, lower bound, 1.28, upper bound, okay? There were more myocardial infarctions in the bypass surgery arm and more episodes of unplanned revascularization in the PCI arm. I'm sorry, more myocardial infarctions in the PCI arm, more unplanned repeat revascularizations in the PCI arm, but there were fewer strokes in the PCI arm. So kind of what we've seen in other trials overall. So it's still debatable when you've got one of these patients, and I would use some common sense. Ischemic cardiomyopathy might benefit in terms of reduced mortality when they've got multi-vessel disease. If they're simple and straightforward and you think you can get a good result with PCI, it's probably reasonable, but probably the majority of these patients should still go to bypass surgery. Okay, now what about the relief of angina and anginal equivalent symptoms? Because the reason that we revascularize patients with stable coronary disease is not only to improve their prognosis, that is, reduce death and myocardial infarction, but it's also to make them feel better. And here we definitely make them feel better with revascularization. So we looked at, in the ischemia trial, a very sophisticated assessment of quality of life using the Seattle Angina Score. This is the Seattle Angina Score's total summary score, which looks at 4 different domains. And you could see that patients who had invasive treatment compared to conservative treatment at 3 months, there is essentially, as John Spurtis described it, a 100% chance that they feel better with an invasive approach. And that maintained at 12 months and at 36 months. Okay, so choosing the right patients for PCI and the right patients for CABG, you get now with drug-eluting stents with PCI, you get definitely better quality of life with an invasive approach. Now, it does depend, though, on how symptomatic the patients are at baseline. So, for example, if you look at their Seattle Angina Questionnaire summary benefit by the baseline angina frequency, you can look at this in the so-called Seattle Angina Frequency domain, and it's a score of 0 to 100, where 100 is no angina whatsoever, and 0 is essentially you're having angina, multiple times a day. So it's daily, weekly, monthly, and no angina according to the score. And you can see here that if you are having weekly or monthly angina, not even a lot of angina, but you're just having angina, those patients feel a lot better if they have an invasive approach. And this is the 3-month outcome. These are the 3-month curves. So a minimal clinically important difference is 5 points. And so they feel 10 points better on average in their SAC summary score. On the other hand, if they were asymptomatic at baseline, then there's actually no difference between a conservative and invasive approach. If patients feel they have no symptoms at baseline, even though they have double or triple vessel disease, even though they have 10% or greater ischemia, you can't make them feel better. And I've already showed you can't make them live longer. And you can see this curve looks the same pretty much for month 12 and month 36. Perhaps it gets a little more clear if we want to see, can we make them angina-free, completely angina-free according to their baseline angina frequency? So here, if you look, if they're having weekly or monthly angina, you can see the curve, it would be exactly the same with monthly angina. You can see the likelihood of being angina-free at 3 months is about 45% with an invasive approach versus 15% with a conservative approach. So very early on, we much more rapidly make patients angina-free. It's not 100%. A lot of patients are still having angina, or at least symptoms that they think are angina, and some of this may be microvascular disease, some of it may be incomplete revascularization and other factors, but clearly better with revascularization. On the other hand, if they're asymptomatic at baseline, 90% of all of them are asymptomatic at 3 months. And there's no difference between the invasive approach and the conservative approach. And again, these curves look the same pretty much at 12 months and 36 months, although they start to narrow a little bit at 36 months because of crossovers. So now if we put all this data collectively in the largest, most recent meta-analysis that was done, 14 randomized trials, almost 15,000 patients with a mean weighted 4.5-year follow-up, we can see that there's a clear improvement for angina that favors revascularization, and there's a 36% reduction in new onset unstable angina that favors revascularization. So we're reducing cardiac death, reducing non-procedural MI, reducing unstable angina, and making people feel better with revascularization and stable coronary artery disease. When we get to the sickest patients, those with severe multivessel or left main disease, that you say you've got to do revascularization, what about PCI versus CABG? Well, there have been a few formal quality of life studies in the bigger trials. So this is the Syntax trial of 1,800 patients with triple vessel left main disease, randomized to PCI with first-generation Taxus drug-eluting stents versus CABG. And what I really want to show you here is 2 main points. First of all, here are the 4 domains of the Seattle Angina Questionnaire: angina frequency, physical limitations, quality of life, and treatment satisfactions. And the first thing that you note is that both groups get markedly better within 30 days after revascularization, which is the next time that the next assessment was done. Markedly better. If you look at angina frequency, they go from 70 to 90, okay, for their group means. And you can also note that there's not much differences between PCI and CABG. Okay, the only real big difference is within the first 30 days. In the first 30 days, when you look at physical limitations, the bypass surgery patients are feeling the same or sometimes even worse. The PCI patients feel better. But then there's a quick catch up. So by 6 months, it's almost caught up. And by 12 months, it's totally caught up. And then it's maintained throughout 5 years. So you can see sometimes in long-term follow-up, quality of life, some of the aspects are a little bit better with PCI or CABG. Other times there's no difference. But again, the big point is they both feel much, much better. And especially once you get through that first 30-day hit to recover from surgery. Doesn't matter whether it's PCI or CABG. And in the XL trial, when you look at left main disease with the same formal quality of life study, you see the same thing. 30-day SAC physical limitations. The bypass surgery patients are not doing very well, but they catch up quickly by 12 months. And then you can see no differences between PCI and CABG in terms of quality of life. And then finally, all of that was stable coronary disease. And most of our cath labs, 50 to 70% of what we're doing is acute coronary syndromes. So that's either STEMI or non-STEMI, and some people would lump unstable angina in here that's a troponin negative. So if we first look at STEMI, and I'm not going to go great into depth in this because you really know this, comparing a primary PCI versus thrombolytic therapy, which is our best medical therapy in STEMI, you could see from the first PAMI trial, of which I was one of the co-PIs on, to 23 randomized trials of PCI versus lysis. We reduce death, we reduce reinfarction, we essentially eliminate hemorrhagic stroke, which comes from lytic therapy, and thus we reduce the incidence of total stroke. We reduce recurrent ischemia, unplanned revascularization, we salvage more myocardium, the patients go home sooner, they return to their ADLs and their work faster. It's a huge, obviously, giant benefit of PCI compared to lytic therapy. That could be the next grand rounds. And we can do even better than that, because when we have higher risk patients with multivessel disease, we know that if we revascularize the non-culprit lesions, if we revascularize the multivessel patients get complete revascularization, we have a substantial reduction in myocardial infarction and unstable angina from the complete trial here. And this is just based on angiographic diameter stenosis greater than or equal to 70%. Once a patient has presented with a STEMI, they're more likely to have vulnerable plaques elsewhere. They've got greater disease activity. If you see more than 70% stenoses, just go ahead and fix them. When we get to even sicker patients with STEMI, those with shock, cardiogenic shock, of course, we know from the shock trial that early revascularization with either PCI or CABG reduces mortality in shock by about 10%. And of course, I didn't put a danger shock slide in here, but we can do even better and further reduce mortality by about additional 10% by using an Impella in patients with cardiogenic shock who undergo PCI. And then finally, non-ST segment myocardial infarction. We've got about 7 randomized trials, 8,400 patients with mean 2-year follow-up. And there's once again a 25% reduction in death and about a 17% reduction in myocardial infarction, favoring an invasive approach. And here the invasive approach is PCI in about 65% of the patients, CABG in about 10% of the patients. That's about what it turns out to be. But overall, that reduces death and myocardial infarction. So, my summary slide. We've got a lot of data here. Who are appropriate patients for revascularization in the post-ischemia era? Well, let's look at stable CAD and let's look at acute coronary syndromes, mainly STEMI and non-STEMI. For stable CAD, and I say after a heart team discussion for patients with left main and multivessel disease, left main disease, we're going to revascularize with either PCI or CABG for improvement in survival. In patients with heart failure and reduced LVEF, we're going to revascularize them for improvement in survival. Probably mostly CABG, but some patients will certainly PCI. Patients with extensive coronary disease, improvement in event-free survival, as I showed you from the ischemia trial. All patients, and this is according to individualized choice, to reduce cardiovascular death and spontaneous MI. You should talk to your patients about the difference from cardiovascular death and non-cardiovascular death and all-cause death, and spontaneous MI versus procedural MI versus all MI. But there's clear evidence that all patients will get a benefit in terms of less cardiovascular death and less spontaneous MI, although it's a very small benefit. Don't overpromise. And finally, for symptomatic patients, for improvement in symptoms and quality of life. So you might say this is pretty much everybody, and it is pretty much everybody, okay? The patients really that you need to know about are patients with silent ischemia, that right now, overall, you're not going to make them feel better. That's very, very clear. And they're not going to have a difference in all-cause death or all myocardial infarction. So you've got to talk to your patients about some of these absolute benefits in magnitude as well as relative benefits in magnitude, and talk to them about the trade-offs. You're going to have some patients, for example, who are having angina that say, I'm scared to death of PCI or CABG, and you're going to tell them, well, your survival is probably pretty similar. Let's try anti-anginal meds first and see how you're feeling. And if that works for them, great. And if it doesn't, then they can always have revascularization. Other patients, I don't know what it's like in Georgia, but I can tell you New York, they want to be angina-free tomorrow. Okay, and the way to make them angina-free tomorrow is going to be revascularize them, particularly with PCI. After CABG, they'll be angina-free in a month. At least in terms of what they perceive as chest pain and angina. So you got to talk to the patients and take their temperature as to their assessment and appetite for risk versus these benefits. Patients with acute coronary syndromes, it's much more clear. We need to revascularize them for improvement in prognosis, that is freedom from death and myocardial infarction. So I'm going to stop there. I'm specifically not speaking about the recharge trial. Because recharge, we're looking at particularly quality of life, and we're looking at it in women, Black, and Hispanic patients. Emory, I should have put these slides in, at least some of them for Emory, because Emory is the leading enroller in recharge, and we're grateful for that. You guys are doing fantastic. But most of all the data I showed you is based on white men. Okay, 80% of the patients are male, 20% female, so it's not a big enough subgroup population to really understand how women do. And very few of the patients in these trials were Black or Hispanic. Black patients, probably 8% of patients on average in the US, less than 1% of all the patients in Europe, and Hispanic patients, probably 1 or 2%. So we're doing recharge to fill that evidence gap of PCI versus CABG in patients with multivessel and left main disease, in women, Black, and Hispanic patients, looking for outcomes that are important to patients, which is really living longer and living better with an improved quality of life. So let me stop there and open it up for some questions.
Greg, thanks so much. That's a very comprehensive overview of the role of revascularization. We do have a question from the chat. Dr. Michael McDaniel is asking your thoughts on, is non-fatal MI a hard outcome for revascularization trials, as there is no correlation between reduction in MI and reduction in mortality? And should future trials omit non-fatal MI in the primary MACE outcome? Would total mortality and quality of life be a better MACE composite?
Yeah, great questions. So there is a relationship between myocardial infarction and subsequent mortality. And it's definitely stronger for non-procedural MI than procedural MI. Okay, most of the procedural MIs that we measure are elevations in troponins or CKMB, and are not strongly associated with increased mortality. But when you get to a CPK of greater than 10 times, or standard troponin of greater than 70 times the upper reference limit of normal, then we find about a 2 or 3-fold increase of risk of mortality in associative relationship and subsequent long-term outcomes. But those are the big MIs. So those are 1% or less of the peri-procedural MIs. Non-procedural MIs are clearly related to subsequent mortality. And as I showed you that, even there, in the meta-regression, there's a relationship between cardiac death and long-term spontaneous MIs that we don't see with procedural MIs in those studies. So I think it is important to prevent non-procedural myocardial infarctions in particular. And again, doing a really good job with complete revascularization in most of these syndromes does that.
Greg, it's a great talk. It's extremely comprehensive. Answer a quick question for me. Somewhere in the Stitch trial, we kind of the whole discussion of the surgical ventricular reconstruction just has been kind of left to not be discussed anymore. Where does that fit into this? Is there any role for that? And they were half the patients, I guess, that got surgery during the trial. So it sort of muddies it up a little bit, but nobody seems to want to talk about it.
Yeah, so about half the patients, as you mentioned, who got surgery were randomized to either surgical ventricular reconstruction or not, so like a door procedure, and there really was no benefit in those patients. There didn't seem to be an interaction between the reduction in mortality or not in those patients, so it didn't affect the overall main outcome of Stitch. That trial's been criticized for a lot of reasons. They did not get nearly as much, the Stitch operators did not get nearly as much reduction in left ventricular end diastolic and end systolic volumes as other studies have shown. When they did make the ventricle really smaller, it appeared as if there was a reduction in mortality. So it may have been a technique thing, but nonetheless, because of that negative trial, I don't know what the latest recommendations are for SVR in the surgical literature, but I would imagine they're either class 3 or class 2B. So it's rarely done.
Good morning, Greg. This is Tanvir. How do you carve out which patients best benefit from revascularization with severe cardiomyopathy? I mean, you've shown us the data. Who really benefits? How do you predict which one would benefit?
Yeah, so it's a great question because they're much higher risk, and they're much higher risk for revascularization. So look, I think the first thing you do is you take the Stitch trial on its face, and pretty much all you need is an ejection fraction less than or equal to 35% and multivessel disease. But within that, we know that most of those patients were stable, and most of the patients in the BESIS-2 trial were particularly stable. And I've talked to the Divik Pereira, the PI of that trial, and they were basically calling patients at home who were stable, telling them, look, we have a therapy that might make you live longer, which is PCI in your condition. And even though these patients aren't having heart failure symptoms and aren't having any angina, those are the ones they revascularized. Stitch, not quite so bad, but all those patients did not have much disease activity. I can tell you that patients who are having a lot of disease activity, patients who are having more florid heart failure, patients who are having a lot of angina, those are going to be the patients who are going to benefit more. That comes from registry studies and observational studies. If you look at PROTECT 4, okay, and we haven't reported any data from PROTECT 4, that's a randomized trial of PCI in surgical turndown patients with a very complex coronary disease and reduced left ventricular ejection fraction below 40%. Those patients, most of them are NYHA class 3 or 4, and most of them are class 3 or 4 angina, okay, or recent non-STEMI. So a totally different group than the patients that were enrolled in either the STITCH trial or REVIVE BESIS 2. So again, those patients aren't going to live without revascularization. So the sicker they get, in general, the sicker they get, the more they're going to benefit from revascularization, although the higher risk they are.
So, Greg, if you have severe multivessel disease, if you were to target one set of vessels, whether it's, should you just target the left main approximate LAD and see what happens? I mean, what is your thought on that?
Well, we don't have, obviously, randomized trials of complete versus reasonably incomplete revascularization in patients with stable coronary disease. We do in patients with STEMI, and I showed you the complete trial, which basically is a trial of complete versus incomplete revascularization after a STEMI. Those patients clearly benefit. There's numerous meta-analyses. There's now even new meta-analyses coming out that there's lower death in STEMI after complete revascularization with multivessel disease patients. We don't have that data yet in stable CAD, although there's been more than 50 different observational studies that have then done either propensity adjusted or multivariable analyses to try to see if complete revascularization is associated with improved survival in stable CAD. And in general, it is. In most of the studies, it is. But those are associations. And it's really hard without a randomized trial to know if the patients who got complete revascularization were those who had good targets and who were having a good procedure without complications, whereas in the ones who started getting complications, they stopped and they got incomplete revascularization.
Greg, I'd mentioned severe cardiomyopathy. If you had severe cardiomyopathy with multivessel disease, should you just target the left main approximate LAD, for example? That's what I meant.
Yeah. So again, all you can do is make educated inferences, okay, from the data that we've seen. And the data that we've seen in STITCH, okay, they went for complete anatomic revascularization, which they achieved in most cases. And they couldn't really show that that led to better outcomes, but because everyone benefited in STITCH on average, right? Group mean, whether or not they got complete revascularization or not. In most stable CAD patients without ischemic cardiomyopathy, complete revascularization is associated with better survival. Is that also true in the sicker patients with ischemic heart disease and cardiomyopathy? I would think it probably is. That would be my educated guess. However, you don't want to go crazy. I mean, most of those patients have renal insufficiency. The vast majority of patients with a low LVEF and multivessel disease, 3/4 of them are going to have renal insufficiency. You don't want to go after every chronic total occlusion, especially if it supplies non-viable myocardium, although that's still a hypothesis. Okay, so I think you just got to use, some of these cues from the trials in less sick patients to determine which patients are going to benefit and how far you should push. In general, the more revascularization, the better. And I do think that's one of the benefits of bypass surgery in a lot of these conditions where you can only get incomplete revascularization by PCI. And we have to be cognizant of that.
Greg, one of the questions we had in the chat is how do you reconcile the decreased cardiovascular death with the increased non-cardiovascular death seen in ischemia?
Yeah, so, again, that's created a lot of controversy. My own view is that the reduction in cardiovascular death is probably real because it correlates with the reduction, the long-term reduction in type 1 myocardial infarctions. And I think that relationship is real. And the reduction in non-procedural myocardial infarctions is real. And the curves spread over time. So I do believe that's probably real. So then the real question is the reduction in non-cardiovascular death real? Okay, and I can tell you, we have looked in ischemia at every possible cause and, late infections. Tell me why PCI causes infections 7 years later. Okay, I tend to think it's probably a chance finding. And so my own, and I also tend to be an optimist. So I tend to believe that revascularization probably gives you a small benefit of mortality in these patients. However, other people would say it's very hard to adjudicate between cardiovascular and non-cardiovascular death. I don't think it's so hard. I've designed a lot of, I've overseen research units, okay, for 25 years at the Cardiovascular Research Foundation. I've taught them how to adjudicate events. If somebody dies of pneumonia and sepsis, okay, or if somebody dies of stage 4 cancer, and they come in and have a cardiac arrest with, stage 4 cancer bleeding out, that's obviously a non-cardiovascular death. If somebody comes in with a primary myocardial infarction, that's obviously a cardiovascular death. So I don't think it's that hard to adjudicate, but overall, those are the data. Again, the most important thing I'd emphasize is it's a small difference. Don't revascularize patients with stable coronary disease because you're going to tell them you're going to have a large difference in survival. Okay, and they might have a small difference in survival. When it gets to left main and multivessel disease, then I think the difference in survival is probably going to be bigger. Okay, but again, stable CAD has a pretty good prognosis in terms of survival.
Greg, thanks for doing this. I really appreciate it. It was great talk.
Great, my pleasure, guys. Thanks a lot. Hope to see you soon.
Yeah, take care, man.
The preceding program is copyrighted by Emory University.